Yeah, okay. So it's actually something which we've been doing a fair amount of in our local system. So way back when I first started, one of my first jobs in the CCG, or one of the first things that I was working on, and had a clinical fellow working with me, was developing a minimum data set around frailty. So that actually, whatever part of the system, whether it be general practice, community, acute, um, this is before actually we'd made that shift to SNOMED. So it's more the more the read codes that we were looking at actually, but we then did the mapping work across the SNOMED. Was to sort of say, well, when we do a frailty assessment, or when we do record somebody's falls risk, or when we gather that piece of information, what do we want? You know, what code should we be using? What standard should we be setting? And so that supports the information sharing, so that if that person then hits another service, or is seen by another service, that can then be surfaced and shared in that consistent way. And then from my point of view, from that population health point of view, we can start to analyze that data in a more standardized, structured way. And so one of the things that we actually had quite a lot of success with was working with our clinical leaders to sort of define what are the key pieces of information that we really want to gather, linked to our local pathways, that are really important to be gathered in a systematic and structured way. And we're now doing a bit more of an extension of that with a sort of data optimization plan, looking at some similar sorts of approaches to sort of create some common standards around the data that we record, so that it does inform what then gets shared through into our shared care records, but then also helps the analytics from that sort of health system planning side. So we know how many people are living with moderate frailty and are on 10 medications but haven't had a polypharmacy review in that locality versus this locality. So we can start to sort of do that, addressing, as you described, those inequalities. Now, I don't think that's necessarily getting into that really exciting space of the wider data sets, but it's making best use of the richness of the data that we actually still do have at hand, just from the NHS.
Okay, so if we take something specific like inequalities, for example, yeah. So that would be a central pillar on any ICB strategy, national priority, all the way down into providers as well. So we have an inequalities report that's going to our board for the first time this month, which is great. I put it to you that in studying inequalities, using the index of multiple deprivation for deprivation and using the census categories for ethnicity are pretty blunt. And that's before you get into traveller status, people with learning difficulties, people who are blind, people who can read Braille, or blind who can't read Braille, and all sorts of things which aren't recorded very well. Can you, given your kind of role in public health, what's your approach? Well, firstly, do you agree with the challenge to some extent or not? And if so, how might you go about collecting data which is more nuanced and ultimately more useful?
Yeah. So I think they are blunt tools, the index of multiple deprivation. And then I think if you're getting into the slightly more nuanced 17 levels, I think you've got your top level ethnicity 5 categories, and then I think 17 underneath it. Yeah. You're starting to get again into a little bit more nuance. But so I think that they are still really important. And then you can break down, for example, index of multiple deprivation into the 7 domains and start to look at just health. Yeah. So I quite regularly, so we were talking earlier about outcomes. Because we've got linked person level data, pseudonymized for us in the ICB, for that we're able to build indicators out from, we can then look at each of those indicators by all of those characteristics: age, ethnicity, deprivation, carer status, whether they're veterans. So all of those other things that you were describing, homelessness, gypsy traveler, Roma communities, characteristics like that. Again, if it's recorded and captured accurately in a systematic, structured way in the records, that gets pulled through into that longitudinal linked record. And then when we're starting to surface those outcomes, we can break it down by all of those different characteristics. And so I can demonstrate the variation in rates of emergency admission for falls by deprivation, by ethnicity, by age. I mean, obviously age, but you know, all of those characteristics, and actually the power of that information and playing that information back then helps the teams, the clinical teams, to know where they are most likely to have impact and benefit within the local system.
Yeah, that's really helpful. It tees up a question sort of going back into capability within ICB. So if you had all of those different metrics about an individual, because I would say index of multiple deprivation, it's an LSOA, it's thousands of people, it's very blunt, which I think you're acknowledging to some extent. But at a personal level, if you did know deprivation and ethnicity and age and gender and GP record, and you've got quite a lot of data on, and you, the way you were describing it is you and I'm being pejorative, you sort of profile by age, then profile by age. Now, of course, if you had all these metrics together and you had a data science capability, you could start to build some really interesting clustering out, start to do some risk stratification, but that relies on having some data science capability. And I'm interested on your view on what data science capability you think we have at the moment, need in the future, and how we collaborate on some of that as well.
Yeah, and to that end, I think you're sort of getting into some of the PHM tools that are developing or developed around population segmentation and risk stratification. So I think there's some off-the-shelf ones. So you've got, you know, we talked about deprivation, and I think you've got some other off-the-shelf tools like Mosaic and Acorn and things like that. And socioeconomic status, but that's tied to jobs and so mainly for adults and working age adults. But so we've done a lot of work around this, working with Optum as a third party supplier a number of years ago to look at our data and build a segmentation model, because as you're starting to build in, you know, classically a lot of the segmentation models are very medicalized. It's very much about which conditions or what combinations of conditions you've got. But by actually starting to link in that wider data, the social care stuff, and particularly all of that richness of information in the primary care records, you can start to build a really, really interesting segmentation model. And so our segmentation model locally starts to talk about social complexity. So beyond just that sort of medical, physical health complexity, we're looking at the mental health and learning disabilities and some of the complexity around that, but then also just that wider social complexity. And the more information sets, the more data sets that you start to get incorporated into that, the more you can get into the nuance of what really drives that social complexity, and social complexity across different age groups as well. But yes, you're absolutely right. Coming back to your question, which is around what skills do you need?
Where's the workforce that's going to do that? I know there's lots of off-the-shelf stuff, and there's some really interesting risk strat tools, some UK built, some US built. But the opportunity that you describe, which is really exciting, is we're sat on some really good data, and the more that we move social care data alongside NHS data, housing data, air quality data, and so on, that takes you into a world of building, you know, all sorts of things, neural nets and clustering solutions, and you know, you could do it at a relatively simple level or a neural network or whatever. But you're going to need some people who've got maths degrees, and I put it to you that there aren't loads of them, so we just need to work out the best way of collaborating on some of this. I think.
And I think there's the collaboration around the building of these tools, and then there's also the sharing. It's where, you know, I'm always happy to share the work that we've done locally with anyone and through the network. And then I think that, but going hand in hand with any sharing has got to be the inputs that you need in order to produce this output are A, B, and C. So that we begin to get into the this segmentation can be rolled out at scale. And in order to really sort of truly inform it, you know, these are the sorts of data sources that you need to be inputting into the model. Because I think a lot of this does sort of feel a bit black boxy, doesn't it? It's kind of that it gets outsourced, because I'm not sure that there is a huge amount of resource in-house. And I think where it is in-house, it tends to be quite fragmented, or it's out there out there in the local systems.
Yeah, no, I agree. We've built models in the past just to predict how many ambulances are going to come and at what time they're going to come, and we did some quite sophisticated statistics, and we had quite a good model, but no one understood the model. What we then did is we took the average of the last Tuesday afternoons at 2:45 and said it will be something like that with an 8-week roll. And because everyone understood it, everyone kind of engaged in the data. And I think we're at a really interesting point at the moment where people are going to have to. We can have some explainable AI coming down the tracks, but people are going to have to put trust in some stuff that they cannot understand. You know, we're doing some work around clinical decision support and around frailty, actually, in deteriorating patients. So quite interesting to you, hopefully. But the level of statistics that we're applying to that, I can't replicate. You know, we're having to work with experts who are taking a whole series of clinical indicators and are going to predict if a patient is going to deteriorate or make their discharge date or whatever it is. But those statistics are not explainable to me. So it's a really interesting time, because with this promise of AI, and more specifically data science, we're going to have to trust in some people who are better at maths than us.
Yeah, and I think part of that is, you know, to build that trust, I think we need to articulate the process. I think people will be able to buy into it if they understand that it's gone through a rigorous process. So locally, we are working with our local providers, Oracle, to build a local risk stratification model. We've got a population of 1.6 million. So we've got quite a big scale to work with, and we want a tool that is localized, but then can be generalized. And so we've worked with them, and they've been really clear with us about the methodology that they've taken us through, and how they've done a combination of literature review, looking at examples of existing risk stratification models, and how they have analyzed our local data to develop the risk model. And that is something which then I can then take and play back with the local clinicians to sort of talk them through the process, so that they have confidence in the tool that we're looking for them to use. And I think if it looks like this black box, there's going to be there will be just an ever higher level of skepticism. And I think I don't need to. I'm not going to be able to describe it all in its entirety, and I'm not sure that people listening would necessarily want to or be able to understand all of that nuance. But I think just giving them the information on some of the process that we've gone through it really helps with the engagement. So I think that's probably the balance that we can try and tread to get that engagement in those tools.